Kalimera, good morning, and welcome. I'm Mary Bussell, and I'm with the Economist Intelligence Unit, a sister company to the Economist newspaper and all part of the Economist group. It is a true pleasure to be with you today, although I am sincerely disappointed to be unable to join you in person. Today, we have a unique opportunity to learn how Greece is working to maximize the opportunities for improvement and create a new future, building systems and meeting the needs of people living with lung cancer. Breathing in a New Era, a comparative analysis of lung cancer policies. Excuse me, please go back. I'm not quite ready to advance the slides yet. Sorry, thank you. This is based upon research conducted in a pre-pandemic world. We can see where breathing new life into past paradigms can change the way we address the burden created by lung cancer. And today, we look to the future in Greece's agenda for lung cancer in a post-COVID-19 world. Now, if you let me, I will walk you through the findings in our study. So the first slide, please. Thank you very much. Breathing in a New Era, a comparative analysis of lung cancer policies across Europe, was a report that I did with the Economist Intelligence Unit, part of the Economist group. Our research centers on assessing unmet needs within health systems and opportunities for improvement. Our goal is to highlight and improve outcomes for people living with lung cancer by providing an impetus for the improvement of cancer plans and national policies in 27 countries across Europe and 9 countries in the Asia-Pacific region. Our initiative has expanded knowledge and fostered debate around priorities for improving care in each country. Our aim was to explore how differing policy environments partially drive variations in lung cancer outcomes to inform policymakers, public health authorities, and society as a whole on the most urgent issues confronting lung cancer and suggest a platform for action. Next slide, please. This is a slide of our framework. And this framework gathered national level data to enable cross-national comparisons. However, some countries do not organize their data at this level. Some have fully devolved health systems, and others allow particular decisions to be made at a local level. We looked at 17 indicators, which we grouped into 5 domains. We find patches of good practice throughout the countries we've studied, yet no single country or single domain scores highly across the board. Country-based workshops enabled us to dive more deeply into the issues within each country, allowing us to explore the differences within a country's borders. We met with over 200 clinicians, patient organizations, policymakers, and payers, groups who had not sat round a table in this capacity before. The energy and discussions were fascinating. In Finland, the Director General of the Institute of Health and Wellbeing announced how lung cancer is going to receive much higher priority in her country. The momentum for change is here. Next slide, please. Our first domain looked at lung cancer as a strategic priority, focusing on the degree to which this disease is a national focus. We looked at national cancer control plans, which are produced by the government's Ministry of Health and help to demonstrate that a country recognizes the need to prioritize and address its cancer burden. Good plans provide details on the prioritization and coordination of programs, including awareness, prevention, early detection, and treatment. High-quality plans are regularly updated, realistic, and goal-oriented, with a detailed implementation plan and an appropriate, sufficient, and clearly identified source of funding. Without a plan, little coordinated action is likely to occur. The National Cancer Control Plan in Greece has not been updated since 2011. It does not present an implementation plan, and it does not identify a funding source. In addition, the government or health ministry has not published a specific lung cancer control plan. Next slide, please. Lung cancer clinical guidelines are produced by medical specialists, and in some countries, they are endorsed by the health ministry. They help to establish national benchmarks, which can aid in the alleviation of variations in care because they guide clinicians' healthcare decision making. Therefore, they need to be a comprehensive, useful guide for clinical practice, formalizing standards in the treatment of disease and encompass all aspects of care with clear pathways, timeframes, and quality indicators. While guidelines establish benchmarks and hold providers to account, they cannot guarantee the delivery of care they describe. Gaps can emerge between what is prescribed in the guideline and what happens in clinical practice, resulting in patients not receiving appropriate care. High quality, evidence based clinical guidelines should cover screening and early detection through to treatment, including psychological support as well as supportive and palliative care. Ideally, they will also describe the incorporation of multidisciplinary care teams and ensure that the role of the patient through shared decision making. Shared decision making should be part of a patient's entire journey, but the guidelines in Greece only discuss this as a follow up for complications. National clinical guidelines in Greece do not include supportive and palliative care. Early detection is vital to improve outcomes, and yet screening remains a controversial issue for many countries, but it is no less controversial than screening for other diseases. National clinical guidelines in Greece were last published in 2011 and do not endorse screening, but they recommend low-dose CT with the caveat that the effect of low-dose CT screening has not yet been supported. There has been significant growth in scientific knowledge and advances in diagnostic and treatment options that are not reflected in these old guidelines. In May 2011, the results of the National Lung Screening Trial in the United States was a pivotal event as it showed that early detection through screening successfully identified a high rate of early-stage lung cancer. This is further substantiated in the final reports published by the Nelson trial in January 2020. This was the largest European randomized control trial to demonstrate a reduction in lung cancer mortality with low-dose CT screening in people at high risk for lung cancer. Results showed that the benefits of low-dose CT were even larger than found in the US study. There is no evidence to show that Greece has conducted a lung cancer screening study or trial. Participants in the workshop I attended in Athens noted that national strategies for screening have been lacking, and they felt that sufficient research has been already conducted, and they called for action on the implementation of screening programs, not further screening studies. Next slide, please. Lung cancer is a race against time. This domain addresses early diagnosis, fast tracking, and rapid referral to treatment. How well do countries address the need for speed? Because time is of the essence. Guidelines in Greece can help to improve awareness in primary care, ensuring patients are identified early in the disease process. They must be revised to ensure that a person suspected of having lung cancer is fast-tracked for diagnostic testing that is delivered within specified timeframes. Next slide, please. In lung cancer, there is no time for complacency. When someone has received a diagnosis of lung cancer, the guidelines must specify the steps to be taken to rapidly refer him or her to secondary or tertiary care. We look for comprehensive lung cancer clinical guidelines because these are the documents that are top of mind for clinicians when delivering patient care. Specifying that newly diagnosed patients are rapidly referred to secondary or tertiary care is missing from the Greek guidelines. Next slide, please. Stigma subsists on a lack of understanding and fear. Minimizing stigma can be achieved by providing the general population with information. A challenge with lung cancer is that many sufferers feel guilty, as well as a sense of stigma associated with the disease linked to smoking. But tobacco is not the sole culprit. Approximately 10 to 25% of lung cancer worldwide occurs in never smokers, and these are defined as people who have never smoked or smoked less than 100 cigarettes in their lifetime. Research has revealed that the complexity of lung cancer has shown that it has varying histological profiles. Destigmatizing lung cancers linked to tobacco is critically important for ensuring that everyone diagnosed with this disease receives the care they require free of blame. Greater awareness throughout the general population and among primary care professionals can help to eliminate the stigma for everyone living with lung cancer. Receiving a diagnosis of this disease causes immense psychological distress for a patient and his or her family. Despite the availability of new treatment options, this disease may still be considered to be a death sentence. Participants in the workshop I attended in Athens were keen to build public awareness to improve understanding. The clinical guidelines in Greece neither recognize the unique psychological burden of lung cancer nor include a psychological assessment for patients. There is no referral pathway to obtain psychological support services in the guidelines. However, workshop participants noted that some hospitals incorporate the assessment of psychological needs in their individual plans. Unfortunately, this may cause gaps in care and the potential for inequity in the delivery of services. Stakeholders in health and in other sectors must work together to ensure that patients receive the psychological care that can help them. Many patients have reported wanting to obtain mental health support but have not been able to access it. Embedding pathways to obtain support in lung cancer clinical guidelines can help. The lung cancer clinical guidelines in Greece do not mention a referral pathway to obtain supportive and palliative care. And additionally, there was no evidence to demonstrate that oncologists receive training in supportive and palliative care. Next slide, please. The involvement of patient organizations in national assessments of disease and policy development can help to build consensus. In representing patient needs, patient organizations improve decision-making because they can help policymakers and clinicians understand issues from their perspective. However, lung cancer-specific patient organizations only exist in some countries we studied, and where they exist, there is a significant variation in the roles they play in policy development. In some countries, they are nascent organizations and not yet fully established, thus their role is minimal. In other countries, patient organizations are well connected and actively engage with government and stakeholders to increase awareness and contribute to policy development. Greece does not have a lung cancer specific patient organization. Next slide, please. Patients and their organizations can play an important role in the development and adoption of clinical guidelines. They help to identify issues that may be overlooked by health professionals. They can influence the development of recommendations from a patient and carer perspective, and may also emphasize the importance of shared decision-making and psychological assessment. There was no evidence to demonstrate that Greek patients were represented in the development of clinical guidelines or involved in health technology assessments. Next slide, please. With technology paving the way for earlier diagnosis and new treatment offering hope to patients, lung cancer is at a crossroads. The treatment a lung cancer patient receives will depend on the stage at which the diagnosis is made. Treatments can include surgery, chemotherapy, radiotherapy, targeted therapy, and immunotherapy. As of 2020, nearly 20 new personalized therapies have revolutionized treatment for lung cancer. However, access to new treatments can be a challenge for countries with limited resources. Attaining market approval is only the first hurdle. Once approved, a country's health system must determine how these often expensive therapies will be reimbursed. Delays between marketing authorization and availability to patients have a very real impact on patients and their families. Collaboration between stakeholders is necessary to ensure that treatments are available in a timely and financially sustainable way. In order to get an estimate of the availability of targeted and immunotherapies, we looked at the reimbursement status of 13 drug and indication combinations for a range of tyrosine kinase inhibitors and anti-PD-1 antibodies. While Greece performed in the upper tier of our analysis, workshop participants acknowledged that the challenging gap between EMA approval and patients being able to receive treatment with innovative therapies, discussing how fragmentation of the Greek healthcare system contributes to access problems for patients. The increased use of personalized therapies has magnified the need for biomarker testing to ensure that patients get the right treatment for their particular cancer. Biomarker testing has become a fundamental tool, guiding and customizing treatment decisions for patients since 2013. Choosing the right therapy for a specific patient increases the likelihood that he or she will respond to treatment. The 4 tests commonly used for lung cancer are ALK, EGFR, ROS1, and PD-L1. We found that biomarker testing varied widely between and within the countries we studied. While these tests are discussed in the clinical guidelines of all of our countries, there is room for improvement as there is no consistent approach. This can result in situations where an expensive, innovative treatment is reimbursed, but the inexpensive diagnostic test is not. One way of avoiding this conundrum can be found in Belgium. New legislation there has mandated that testing for some, but not all, biomarkers will be coupled with treatment for reimbursement purposes. Next slide, please. A distinction should be made between population-based cancer registry and a hospital-based cancer registry, such as that found in Greece. A hospital-based cancer registry can be used to create a population-based registry, but one is not the same as the other. Hospital-based registries record all cases in a given hospital, often without consideration of the wider population. The emphasis in these registries is on clinical care and hospital administration. A population-based cancer registry records all new cases within a particular population, usually within a geographic area. Workshop participants recognize the importance of having this type of registry in order to develop meaningful cancer policies. Workshop participants in Greece and Hungary felt the quality of their registries was not fully reflected in the rating awarded by our source for this indicator, which was the Cancer Atlas. Next slide, please. The public health domain covers awareness, prevention, screening, and an analysis of the degree to which patient organizations have a role in policy formation. Lung cancer is a public health issue that transcends differing systems of governments, laws, resources, and strategies. Countries can address this by improving awareness throughout their population and within the primary care setting. Anti-tobacco strategies can be strengthened at both a country level and across Europe, and often do not require public investment, only political willpower. Tobacco is recognized as the most important risk factor for all cancers, responsible for approximately 22% of all cancer deaths and 85% of lung cancer cases. The tobacco epidemic, as it's been called by WHO, ranks as one of the most significant challenges to global public health. Europe has the highest percentage of smokers worldwide. An estimated 209 million Europeans smoke, and of these, half are estimated to die prematurely due to their tobacco use. Europe also has some of the highest prevalence rates of tobacco use in adolescents. In the Czech Republic, tobacco use among teens is similar to that in adults. This was the domain in which Greece received its best performance, Yet there is still room for improvement. The country performed moderately well according to the indicators we use to measure tobacco and anti-tobacco policies, but as I learned in the workshop I attended, policies may not always be implemented. Additionally, improvements need to be made in legislation in the use of e-cigarettes. There is some evidence to indicate that e-cigarettes may help adult smokers to quit tobacco use. However, they have not been demonstrated to be any more effective than smoking cessation medication. And the long-term impact of using e-cigarettes is unknown. And there has been concern that use in adolescence may lead to future tobacco use. Policies on e-cigarette availability and usage vary widely in the countries we studied. This area is rapidly evolving, and policymakers have to act on emerging scientific evidence. While e-cigarettes are regulated by law and the sale to people under 18 years of age is prohibited, Greece needs to strengthen legislation further by prohibiting advertising and banning the use in public areas. Next slide, please. Communication plus collaboration and consensus can bring change. There are many opportunities for improvement in Greece, and the momentum is here. We can improve strategic planning by publishing and regularly updating a national cancer control plan, including an implementation plan and an identified, dedicated source of funding. Ensuring clinical guidelines are comprehensive and establish national benchmarks to eliminate regional discrepancies. There is no time for complacency. Early detection is vital. We can ensure that patient organizations are part of the policy process and guideline development. Next slide, please. We need to create systems to ensure sustainable and equitable access to innovations. We need to destigmatize lung cancer through awareness, education, compassion, and dignity. Awareness between and among all stakeholders, from the general population doing what they can do to maximize their individual health, to clinicians ensuring that early detection is a routine part of their practice, to health systems being able to utilize diagnostic tests and initiate treatments without delay, and for governments to recognize the role they play in promoting good, evidence-based public health and helping their populations to maximize the scientific developments and medical innovations we have at our disposal and the new technologies and treatments that are coming. Lung cancer is a European challenge, and it needs to be at the top of every country's agenda, using clinical and public health tactics, because this cancer kills nearly as many people on this continent as breast, colon, and prostate cancer combined. We must work to accomplish our work within the context of SARS-CoV-2, where our global response to this pandemic has placed us at risk of seeing worsening outcomes and increasing mortality for people with lung cancer. A cancerous tumor does not stop growing for the sake of a virus. Lung cancer does not wait for a pandemic to pass. We must breathe new life into past paradigms and change the way we address the burden created by lung cancer. Building partnerships between national stakeholders will promote meaningful dialogue and policy development, forging alliances between ministries of health and public health, finance, social services, and education, and among health professionals and patient organizations can build the momentum for change. This is the time that all people with lung cancer are treated with compassion and dignity, because anyone with a lung can get lung cancer. Next slide, please. We hope that our research can be the impetus for improvement for people confronting a diagnosis of lung cancer, while improving our efforts to prevent the disease from occurring in the first place. So thank you for allowing me to present the highlights of our research to you. Let us all maximize the opportunities to breathe in a new decade. Thank you.